pediatrician, also co-founder and the COO of Strong Children Wellness, Therese Despen, family therapist and the integrated care coordinator at the Child Center of New York, and Linda Rodriguez, senior vice president of behavioral health and early childhood at the Child Center of New York. And we're excited to share what we think is a unique model of integrated care for vulnerable children and families that we're calling reverse integration. So we're going to start today's discussion by first starting with why integrated care is needed. And we'll share the story of a patient who we're calling Alex that really is inspired by a case that we're currently mutually caring for. We'll put Alex's case into context, the context of the Ecobio Developmental framework, which is really a way of thinking about the whole patient. And then we'll talk about some of the limitations of traditional integrated care models, followed by introducing our model of care, which we've called reverse integration. And then we'll talk specifically about the reverse integrated care partnership between Strong Children Wellness and the Child Center of New York. So I wanted to introduce a case of a patient that we'll call Alex. So this picture is a representation, not the actual patient. And he's a 4-year-old little boy, one of 3 siblings. His other 2 sibs are 15 months of age and 6 years old. They recently immigrated from Honduras and currently reside in a domestic violence shelter with their pregnant mom. And when they were in Honduras, Alex and his siblings witnessed extreme violence. And so they came to this country with a lot of traumatic experiences, a lot of trauma. And Alex presented to us with behavioral issues, speech delays. He had very poor dentition, meaning lots of cavities on his teeth and dental caries. And he also had poor growth. When you think about Alex's case, one way to think about it is to apply a framework called the Ecobio Developmental framework. And it expands the biopsychosocial model, which most of us are probably familiar with, by saying that a person's ecology or their community, their social, their family environments strongly influences their genetics, their brain and brain development, and their physiology to impact their overall health and development. One example of this is the science behind adverse childhood experiences. And these are traumatic experiences in childhood that have been shown in study after study to be linked to the major causes of disease and death in both adults and children. And if you look a little bit deeper at how adverse childhood experiences, or ACEs as they're commonly called, get under our skins, you can think about it as ACEs essentially cause what's been termed toxic stress. It raises stress hormone levels in the body to such a level that if it's unbuffered, meaning you don't have the protective, safe relationships that you need to help bring those stress levels down, that high level of stress can actually affect our DNA, can get under our skins, into our cells, cause changes at the gene level in our brains and in our other organ systems, and cause what we term maladaptive behavioral responses such as ADHD, anxiety, depression, and physiologic responses, which result in diseases like cancer, worsening asthma, diabetes, heart disease, etc. And in Alex's case, when he arrived to this country, him and his family really had a pretty fragmented experience of care. And what we know is that fragmented care actually contributes to toxic stress. In Alex's case, he didn't have a regular pediatrician or medical provider. An ACS case was actually opened because someone noticed his horrible dentition and there was concern for medical neglect. His mom was early in her pregnancy and she had never received prenatal care, and she was also uninsured. And in addition to homelessness, they were also experiencing food insecurity and some legal issues. The family was really forced to navigate a pretty complex maze of different systems, including the health system, which ultimately worsened mom's stress level, the kids' stress levels, and it deepened their mistrust of the health system in particular. What we know about fragmented care is that it can lead to higher costs, and it also worsens access and engagement in care and ultimately worsens health outcomes. So traditional integrated care models, which usually involve a mental health provider being co-located into a primary health care setting, while they may help to address issues around accessing mental health care, typically they don't have the resources or capacity to help patients navigate and address their social needs. And we know that social determinants of health are what actually drive up to 80% of health outcomes. Oftentimes, these families are referred out again, to pretty siloed, fragmented social service systems. And like I mentioned, this is often very stressful for a parent to navigate. By taking primary care out of hospital settings and bringing it into community-based organizations like the Child Center of New York that are really trusted by families and by communities, you can essentially circumvent that fragmentation. All of the services are essentially under one roof. It's sort of a one-stop shop. And parents and children, families can receive integrated, coordinated support for their physical health needs, mental health, traumatic experiences, and their social needs, which include financial hardship, legal needs, and housing instability. And so out of a shared concern that fragmented care was really driving health disparities, particularly in communities of Southeast Queens and other healthcare deserts, the Strong Children Wellness, which is a medical practice that was founded by 3 pediatricians, myself, Suzette, and another pediatrician, Dr. Omalara Uwemedimo, we joined forces with the Child Center of New York to address this concern. And the 3 of us, Suzette, myself, and Omalara, are all African-American, first-generation immigrant women. And I say that because we really felt strongly that we needed to respond to the need for culturally and socially responsive coordinated care for vulnerable children and families who reside in these communities that historically have not had good access to high quality comprehensive health care. And so what we do is we bring primary care office hubs and telemedicine into trusted community-based organizations that already offer a wide range of services and supports for families and are really the experts at addressing the psychosocial determinants of health. We really prioritize what we call value-based care. So care that is high quality and produces value for families rather than volume-driven care, which is typical of the healthcare system. You often have to see as many patients as you can in the span of an 8-hour day. And that really does not produce high quality care. I'm going to turn it over to Linda to talk more about the Child Center of New York and the range of services that they offer.
So the Child Center of New York is a community-based organization and really started with mental health services. And very quickly, one of the things that we learned was that families were coming to us with a lot of other needs in addition to mental health. And as a result, what we really started to do was to build out the portfolio of services within the agency to really try and address as many of the family needs as we possibly could. And that really helped us to grow in terms of the divisions across the agency. So right now, the Child Center of New York has 5 divisions. We have a very strong presence in behavioral health and substance abuse. We have a division of early childhood education where we start with pregnant mothers in our early Head Start programs and transition into Head Start and childcare models. We do both center-based and home-based programming in the early childhood division. We have wrapped around additional social service support through specialty programs such as Single Stop, JobNet, work with incarcerated young people as well as adults in televisiting services. We are a health home provider for both adults and children, and we also have a very extensive portfolio of prevention services that are throughout Queens, Brooklyn, Manhattan, the Bronx, and Staten Island. We really look at being able to serve in communities that are the most underserved. And one of the other large communities and one of the other very large divisions is in our youth development division. And so a lot of what we are able to do is really look at how do we provide holistic services to children and their families, regardless of whatever avenue they are coming to us from. In terms of other supportive services, our most recent venture has really been in residential care. We have seen from cases that are in our clinics that higher level of care is very much needed for many of the target populations. And so we actually, in the middle of a pandemic, started a residential treatment program in Brooklyn. And so throughout all of our services, I think that one of the biggest gaps that we saw was that while we could really focus on a lot of the social needs, one of the things that kept coming up again and again for us was that children and their families were really not adequately being met in terms of their health needs, and that families were not linked to regular care. Many of them were receiving care through emergency rooms, clinics where every time they went, there might have been a different pediatrician that was seeing them. Our ability to really be able to connect with primary care providers was very difficult, whether that was in our behavioral health division where we were trying to get physicals for children, or whether it was within our early childhood or youth development divisions. And that really helped us to start looking at how do we develop that same breadth of services that we have within the social service realm from the medical side. And so that really started our initial conversations, not only about finding medical providers that could treat families that were also within our agency, but finding physicians that really understood who our families were, understood the circumstances, understood the relationships and the need for secure relationships, and really could understand and give the time and the quality of care that families needed, and to be able to have the best outcomes.
Thank you, Linda. So I'm going to talk a little bit about the Strong Children Wellness Team, and then spend some time talking about our model of care along with our integrated care coordinator. So the Strong Children Wellness Team is comprised, as Nicole mentioned earlier, of 3 pediatricians, all first-generation immigrants, Black women, as Nicole mentioned. Myself, I'm Suzette Brown, the Chief Operating Officer, Nicole, the Chief Health Officer, who we just heard from a little while ago, and Omalara Uwe-Medimo, our CEO. Collectively, we have 30 years of clinical and research experience. Our research spans from trauma and ACEs to social determinants of health, to mental health integration and trauma-informed care. And really, we've all been very, very intentional in our clinical practice about forging really strong partnerships and relationships with community-based organizations who, as Nicole mentioned, we believe are the experts at addressing social needs and behavioral health needs in the communities that we all care about. In addition to the 3 of us, we also have recently onboarded a family medicine provider who's able to see adult patients. And as a result, we really can provide 2-generation care and not just serve kids 0 to 21, but also serve their parents and their grandparents and really provide comprehensive holistic care for the whole family within this model. In addition to the clinical providers, we have an RN who also provides care to both adults and kids, as well as a family navigator who we'll talk about, who's really been instrumental at helping to ensure that families access care and that all of the barriers that usually present themselves when families try to access care are addressed and mitigated. Next slide, please. So the Child Center team includes Therese Despen, who you'll hear about, and she brings 15 years of experience in case management and mental health, as well as James Patterson, who's our referral navigator and has 7 years of experience within the social service field. So the path to this model and our collaboration with the Child Center took place over the course of a 1.5 years, I would say. We actually began our conversations with the Child Center in late 2018. And in 2019, July of 2019, we officially established Strong Children Wellness Medical Group, which is essentially a private family practice that embeds itself in community-based organizations. Around the summer of 2019 through December, we really worked to formalize and establish our partnership with the Child Center. And the Child Center was successful at getting some grant funding to really help with this pre-implementation of this reverse integrated care model. And it was that grant funding was instrumental in really helping to lay the legal groundwork for this model and help us think through and work through all of the logistics. In April, at the height of the pandemic of last year, we launched virtual care because at the time in-person care wasn't possible. And but even though we were providing care virtually, we still maintained fidelity to our original goal, which was to collaborate with the Child Center team to really wrap services around families who needed them, to screen for and identify social needs, and to connect families to the resources that they needed. In June, we began to pilot that collaborative care model, and that of course included the work of Therese and James. And then in August, we were able to finally open the doors to our embedded primary care hub, and we officially launched that hub in early August. You can see a picture of it there. That picture shows our shared waiting area. And then in November, we added a family navigator to our team, and the family medicine provider started in December. So really what we're aiming to do with our model is to empower families, ensure that the care that they receive is equitable, and improve their health and well-being outcomes. So our primary care services include the comprehensive services that most people expect from a pediatric primary care practice. Well, child visits, we also now can provide adult visits, largely virtually right now, but ultimately we'll move to in-person for adult care. And then urgent care. We provide telehealth visits virtually to ensure that families have same-day access to services. But really the heart of what we're doing is this wraparound collaborative care for families that are higher risk. And in doing so, what we aim to do is routinely screen for social, physical, developmental, and mental health concerns that kids and their parents may have. And if families screen positive for those issues, we then refer them to on-site and community partnered services to address those needs. Linda spoke to the breadth of service offerings that the Child Center has, and the vast majority of them are on-site at our Jamaica Family Wellness Center, which we're embedded in, really enabling us to provide a full range of social services, behavioral health services, and physical health services in one single setting. So we've really been intentional about trying to leverage technology to improve the patient experience and ensure access to care and engagement in care. We use a platform that, an IT platform that allows patients to pre-register for their visit on their mobile device. And that same platform also allows us to deploy developmental mental health screening and social determinants of health screening tools so that prior to the visit, we can begin to get a picture of who that child is and what their needs may be. In addition, as I mentioned, we offer virtual care via telehealth and provides care for urgent needs as well as follow-up of chronic conditions. And we also have a HIPAA compliant patient texting platform that allows for bidirectional communication with patients for urgent needs as well as appointments and any other issues that they may have. So what we developed jointly with the Child Center was a screening tool called the Child Center Health and Wellbeing Questionnaire. And that screening tool allows both Strong Children Wellness and the Child Center to identify unmet physical, mental health, and social needs. That screening tool is administered when patients present for their visits. And so in addition to the screening that we do pre-visit on their mobile device, we also augment that pre-visit screening with the Child Center Health and Wellbeing Questionnaire, or CCHWQ. What we found in our screening and who we've been serving include over 75% of patients who are enrolled in Medicaid. And we've identified a significant proportion of kids with unmet physical health needs, in large part due to COVID-19 related office closures of their primary care providers. We've also been identifying fairly high rates of depression, anxiety, trauma, ADHD, and other developmental concerns in our screening. And largely due to COVID, we've been seeing significantly high rates of social needs, primarily around food insecurity and financial hardship. And I'm going to pass it to Therese Depen, our Integrated Care Coordinator, to talk a little bit about our referral workflow.
Hello, everyone. Can you hear me?
Yes.
Okay, great. So what you all are looking at is our site where we share the bidirectional referrals. We also track information about those referrals. For example, which divisions are the referrals coming from? Which divisions are we referring to? We also look at things such as progress on those referrals. So was the client able to schedule an intake? Have they had their intake appointment yet? Or if the client is being referred to Strong Children Wellness, were we able to schedule an appointment for the family? Do they need transportation to the appointment? Has all of that been arranged? In addition to that, we also track the language needs of the clients and the health insurances that the clients have. On this page, we also include all the referral forms. So the referral forms to Child Center of New York, the referral forms to Strong Children Wellness, as well as the CCHWQ, the Health and Wellness Questionnaire that Suzette explained to you on the previous slide. I'm trying to change this slide. Okay, so this, when we receive a referral to Strong Children Wellness, my partner James and I review the referrals. If the referral is for pediatric referral, then I follow up with the family. If the referral is for the family medical provider, then James follows up with the family. So we receive the referral. We call the client to explain that the partnership between CCNY and SCW. We explain to the clients that though we do share a site, we're two separate organizations and that they have a choice in the referral. So just because CCNY referred to SCW or vice versa, the client doesn't have to follow through with that referral. If they prefer to go someplace else, someplace closer to home, then we assist the client with finding another site if that's what they choose. If the client does consent to continue with the referral and they also consent to collaborative care, we forward the referral now to the family navigator with SCW and she schedules an appointment. The client comes in, the client meets with myself or with James to sign the consent forms. Then the client meets with the physician. After the appointment, I schedule the coordinated care conferences between Strong Children Wellness and the team members. I take notes, and then at the end of the conference, each person gets a copy of the care plan. The referral process from SCW is also similar. I receive a referral. I call the client once again to explain the relationship between the organizations. This process is a little different because with Child Center of New York, it's not just, oh, you want to see one thing and then you go right through. We have, as Linda mentioned, 6 divisions with hundreds of programs. So when I get the referral, I now send it to the program, and then I track that referral until the client gets an intake. Sometimes a client can get an intake in as little as a week, depending on the program, and sometimes there's a wait list. So in the meantime, I follow up with their program. Hey, how is so-and-so doing? So-and-so still on the wait list. And then I contact the client, let them know, hey, you're still here. And then once the client has an intake, I inform SCW, we schedule coordinated care conference, take notes once again, and then that care plan is shared with everyone on the team. During the collaborative care conferences, everyone who is in the Child Center and in Strong Children Wellness who is involved with that family is present at the conference. These conferences are held through teleconferencing. So right now we're using Microsoft Teams, which is great not only for the pandemic in order to bring people together, but it's also great because even though SCW is located at our Jamaica hub, we have several sites. And so for programs that are located outside of our site, once the pandemic is over, we'll still be able to continue to have these conferences through these televideos. So in the conferences, we'll have different people. So for example, one family I'm thinking of right now, we actually had a conference yesterday, I think it was. We had health homes, we had behavioral health, and we had strong children wellness. So you have 2 programs within CCNY in addition to the physicians from Strong Children Wellness. During those conferences, we discussed what brought the client into, whether it's Strong Children Wellness or Child Center First, what happens during our individual meetings with the families, how can we support that client, also the family, because sometimes the client, it's one client that comes in and then we find out the family has a need, so then the entire family gets services. So with the example that they gave of Alex, Alex came in, but their mom also had needs that were also addressed. So we don't just focus on the identified patient, we look at the family as a whole. And so everyone and within that family who has a need, it is addressed. We also discuss how the providers can support each other. So for example, we had a client where there was a weight issue, and that was discussed in a conference between the physicians and the therapist. And the therapist now follows up with the client from time to time during her sessions. Hey, how's it going with the changes in your diet? Hey, how's it going with you trying to incorporate exercise into your day-to-day living? So these are the things we discussed during the conferences. At the end of the conference, we scheduled the next meeting. The care plan is shared with everyone, so everyone knows not only what was discussed, but what the continuum of care is, what we're going to continue to do for this family in between conferences. This here is a blank version of our care plan. As you can see, the top is basic demographic information for client, address, insurance, language needs, because we are sensitive to our clients' language needs at the Child Center of New York and at SCW. Being in Queens, just New York City, but most of our programs in Queens, you know, is the most diverse culturally. And so within the staff between SCW and the Child Center of New York speak Haitian Creole, French, English, Spanish, and Bengali. And when we have a client whose language needs we do not meet, we also have access to interpretation services. So all of that is listed here. Everything that is discussed, the continuum of care plan, who attended the conference the next day, all of it goes onto this plan, which we share with everyone involved in the team. And if a new person ends up joining the team, so we have one family who was behavioral health, preventive, strong children wellness, and then health homes became involved. We share the last care plan with the oncoming team member so they know what was discussed and they're ready for the next conference. I'm going to pass this on.
Thank you so much, Therese. So just to put what Therese described in action and using Alex as an example. So in Alex's case, he was referred to Strong Children Wellness, our team, by his family worker at one of Child Center's early Head Start programs in Corona, Queens. And Therese contacted the family once she received the referral and sent the referral over to our family navigator. Her name's Isha Hossein. The family navigator scheduled Alex with the provider, and she helped to arrange for transportation to the appointment, which was an identified barrier on the screening that we did with that family prior to the appointment. And so that mom completed additional pre-visit screening when she got to the office in her language. She was a Spanish speaker. And she signed, Therese met with her, she signed all of the consents needed to do collaborative care and agreed to do collaborative care. And then she completed the medical visit. After that visit, Therese was able to schedule the first virtual collaborative care conference. And in addition to Dr. Brown and Therese, the family worker at this child's Head Start program was able to join in on the conference as well, and just provided an amazing wealth of additional information needed to get a full picture of who this child was, as well as his family. And what we found out during the visit and then in the collaborative care meeting was that this child and the family had a very significant trauma history. We identified the severe behavioral problems and the delays that I spoke about when I first introduced the case. And we ended up having the opportunity to refer this child to early childhood mental health, which is a program that's at the Child Center's Jamaica location and across many of their other sites, as well as to the Committee for Preschool Education to begin to address his delays. A nutritional plan was devised for his poor growth. He was referred to a dental surgeon for his poor dentition. He received catch-up vaccines and other preventive care according to guidelines. And we were able to update his ACS caseworker on this plan of care and all that we were able to do for the family. But as Therese mentioned, although he was sort of the identified child and referred to us, we got to see a full picture of the family and determined that the entire family had needs that needed to be addressed. So his mom did not have a primary care provider. We were able to refer her to our family medicine provider, Amanda, for care. She also was referred to Child Center's adult mental health services. She was early in pregnancy, as I mentioned before, and so she was referred to an OBGYN in the community for prenatal care that works with uninsured moms. And the family worker at the Head Start was able to assist the family with getting WIC, and also referred the family to Child Center's Single Stop program, which helps with public benefits, and they were able to enroll in SNAP and cash assistance. And then the family navigator, because this family we knew needed multiple follow-up appointments with both us, subspecialty, and others, she was able to schedule transportation for the entire family to all of their respective appointments. And, you know, one of the things that's beautiful about this model is that we know that for these families, their needs often change. They're not static. And so the collaborative care conferences for families like this are often held sometimes twice a month, but at least monthly, to find out where they are. Have they engaged in care and services? Are they doing a little bit better? What can we do better to help support them? And then the text messaging we're able to do in the family's language to also check in and make sure that needs are being met. What we're seeing in terms of referrals is that the referrals to Strong Children Wellness from the Child Center, most are coming from their Health Homes program, Early Head Start, preventive services, and behavioral health. And these families really have complex psychosocial needs. And from the Strong Children Wellness to the Child Center, we're referring families mostly to behavioral health, which includes early childhood mental health and child and adult behavioral health services, preventive services, and case management, which is single stop benefits assistance, as well as health home. The vast majority of families referred choose to participate in collaborative care and undergo collaborative case conferencing. So we've learned a number of lessons in the almost year that we've been implementing this. And some of the lessons learned include the fact that this expanded collaborative care team, which again includes everyone, every provider who touches the life of that family, really allows for whole patient care. We're not just addressing a medical issue or a behavioral health issue. We're really putting the family into context and trying to understand all of their many psychosocial and health needs, and trying to figure out how we can collaboratively best meet those needs and support that family. We also have been finding that identifying social needs, behavioral health needs, and physical health needs before the visit really optimizes care planning. You know, most practices really don't begin to understand a family's needs until they present to the office and they have 15 to 20 minutes for the visit, and they can't begin to really get a handle or touch all of the issues that that family may be facing within that short time frame. But getting information prior to the visit using our mobile screening modalities and other outreach efforts really helps us better plan for that family's visit. Also, what we found is that close surveillance of patients in between visits is really important. As Nicole mentioned, families' needs are very dynamic. They change, sometimes weekly. And if you don't keep tabs on that family, you often miss opportunities to intervene and address issues before they escalate to a crisis situation. So we really use our text messaging platform to closely surveil families in between visits and leverage Therese and others to also provide that surveillance. We also have found that patients really like the accessibility and usability of some of the technology platforms we've implemented, particularly the text messaging platform, as well as the ability to conduct video visits really easily. We just send them a link via text message and it opens up the video visit. So that's been very convenient for a lot of families, particularly during the pandemic. They also have really liked the ability to register for the appointment prior to actually coming into their office on their mobile device. We've also found that this model really lends itself to addressing the surge in mental health and social needs that COVID has created. You know, as we all know, the unemployment rate has skyrocketed over the past years, particularly in marginalized communities of color. And this model really allows us to identify and address those needs holistically and again in one setting, as opposed to referring the family to multiple social service settings. Some of the outcomes that we're planning to measure, these are just a few key outcomes listed. There are many more that aren't on this slide. But we really feel strongly and are seeing anecdotal evidence that this kind of reverse integrated care actually improves mental health outcomes. It improves things like depression, anxiety, and ADHD. It improves select aspects of the patient's physical health and has the potential to improve others. We're looking at whether reverse integrated care can actually make a dent in avoidable hospitalizations and unnecessary emergency room visits. We're also heavy on the patient experience of care and satisfaction with care, and have found, again, anecdotally, that this model really improves satisfaction. We're looking at process measures, so number of referrals completed, whether or not the patient engaged in care once they were referred, number of screenings completed, etc. And then finally, we ultimately want to look at costs. Does this model help drive down costs to the healthcare system and to other systems, and how sort of costly is it? Is it an efficient model? So these are just some of the outcomes that we have already started to look at and will be delving more into as our care model progresses. And I'll turn this last slide over to Linda to close us out.
I think we have certainly learned a great deal. But more importantly, I think that our experience has motivated us to want to do even more than what we're currently doing. And as a result, one of the things that we are looking internally within our own organization and within the communities that we serve is to find ways to expand this model. The success that we have found in Jamaica is something that we are looking at replicating across other Child Center of New York hubs, specifically our Flushing location. And we are currently renovating that site, and it will, starting April 1st, fingers crossed, we'll have 2 additional medical offices that will allow us to expand the services that we currently have in Jamaica to also serve the Flushing community. We're also looking to partner and expand the reach of other organizations similar to us that are also have hubs in other parts of the community, and looking at foster care agencies and other community-based partners, so that as Strong Children Wellness is able to expand their services, we can provide technical assistance and support in that process as a partner in making sure that communities are being best served through the reverse integration model. Our goal really is to help as many other organizations be able to do this kind of work as effectively as we have been able to do it within our organization. In order to do that, I think one of the main things that we were very much committed to is making sure that there's a guide for other organizations that can help them in thinking about how do you bring reverse integration into a community-based organization. And as a result, through a grant that we were able to secure, we developed a toolkit that really helps to document the practice, really helps organizations think about how can they integrate medical services into their community-based organizations. And then I think the other area that we are very much committed to and continue to strive towards is how do we look at these changes not just at the community level or not just at the organizational level, but how can we also have an impact on policy and how can we have impact on systems? And so we have really started the conversation with OMH and with other statewide stakeholders to look at this model as an effective model of bringing together health, mental health, and social services on a larger citywide, statewide, and hopefully national platform that can really help affect change within the highest communities of need across New York City and beyond.
Thank you so much.
Thank you, Linda. We'll end here and answer some questions.
Thank you so very much, ladies, for this awesome presentation. You all are to be commended for the great work that you're doing. And this is a great example and testament for celebrating, for the celebration of Women's History Month here in New York City. So again, congratulations. So let us get into the questions. Let's see. Okay, so our first question is, what happens if the family doesn't have access to electronics, Wi-Fi, etc.?
So that's a great question. Thus far, most of the families that we've served have had a smartphone, and can use our technology easily, but there definitely are cases where that phone, is not able to, doesn't have the ability to use some of our technologies. And I think that's where our family navigator and Therese really step in, and they outreach to the family, by phone. If they're not able to complete the pre-visit registration on their mobile device, then some of the screening tools, they'll do it when they come into the office. So we definitely, utilize the staff resources that we have to assist families in whatever way works best for them.
Okay, thank you. Do you all work with families in the child welfare system, specifically bio and foster parents?
So that's a great question.
Yeah, so Child Center has a very large preventive program, so for kids who are at risk of entry into child welfare. And we are now finalizing a partnership with JCCA in Brooklyn, which is a large foster care agency, because again, we really are wanting to be intentional about improving many care gaps in that population. We know that there's often a lot of discontinuity of medical care when kids leave foster care, and they also carry a lot of the traumas, mental health needs, and social service needs that we're seeing in the clients that we currently serve. So the answer is yes, we serve children at risk right now and are finalizing a partnership to be able to serve children in foster care currently. And hopefully that'll be up and running in the late spring.
Okay, so next question. What funding sources support the staff time dedicated to conferencing and collaborating?
Great question. Linda, did you want to speak to some of the funding that is supporting some of the staff time to?
So for components of the program, we do have foundation grants that help to offset the cost of some of the conferencing pieces. Within some of our existing relationships or some of the existing programs that we have, like preventive services, family team conferencing is part of the model. And so we leverage within the collaboration opportunities that already exist in some of those program modalities and formalize it and really work to make sure that everyone can participate. For some of the other programs, such as early childhood, we have the opportunity to have family workers, and so there's an alignment in the work. Health homes, the resource coordinators for health homes are become that conduit for us. And then in behavioral health, we have made a commitment to ensuring that the clinicians can be part of that case conferencing. And so we balance that with the number of billable sessions and then some of the non-billable work that is involved in care coordination.
Jerry, I think you're on mute.
Can you hear me now?
Yes.
Okay. So Linda, can you share with us what the ACS Clinical Consultation is?
So our ACS Clinical Consultation program are social workers that work for Child Center of New York that provide consultation and expertise to the child protective specialist. So we have staff that are in the Bronx field office, the Manhattan field office, the Queens field office, and they work directly with child protective specialists in reviewing cases that are under investigation and helping the child protective specialist make recommendations for supportive service care that might be needed for a family.
Okay, thank you. And my next question that I have here is do you service the entire 5 boroughs, or is there a catchment area?
So we currently, as a practice, serve all 5 boroughs. You know, we have one physical hub location right now in Jamaica, Queens, but some of our families travel from the Bronx to Queens, Staten Island, all 5 boroughs, because they really, I think, you know, get a lot out of this kind of service delivery model. And for those families that reside outside of Queens, we're able to arrange for transportation if they have Medicaid and other needs to get them into our Queen's office for in-person care. Because we also provide virtual care, we can serve families anywhere in New York who have, needs that are urgent and are conducive to telehealth.
And for Child Center, I think one of the things that we have learned during the pandemic is that our clinics in some ways have become clinics without walls. So from the very beginning, we very quickly were able to pivot to telehealth services. And so at least within our behavioral health and substance abuse divisions, as well as our health home divisions, we are able to provide services across the 5 boroughs.
Oh, great. Fabulous. Someone wanted to know, do you service Westchester County?
Strong Children Wellness does. Again, we've seen kids from as far as Westchester, the upper reaches of Westchester, in part because prior to starting Strong Children Wellness, I was a pediatrician and researcher at Montefiore in the Bronx. So a lot of my patients followed me to our new practice. And it spreads in pediatrics, I guess. And so we do see kids as far north as Westchester.
Awesome, awesome. So is the toolkit currently available and how can we access it?
So we're, Linda, I'm sorry, did you want to speak to that? So the toolkit has been developed. We haven't started disseminating and distributing it yet, but for folks who are interested in learning more about the model and would like some technical assistance and more information, feel free to reach out to us at Strong Children or Linda at the Child Center, and we'll be happy to talk more.
Okay, thank you. I have time for maybe a couple of more questions. Do you have recommendations for agencies who are just starting to collaborate on care integration and reciprocal referrals? And if you do, where should they start?
Linda, did you want to take part of that question?
Sure. I think one of the things that we see, especially sometimes in community-based organizations, is a very siloed approach to services. And so I think that the place to start and what has really been beneficial for us is identifying who will be that integrated care coordinator. So who will be that point person that is going to mediate between the medical side and then the social service CBO side. And that could be an existing person that you have within your organization, or that might be something that you feel that as an organization you may want to invest in creating a position for. But I think that what has been successful for us has really been the development of the integrated care coordinator in making sure that that all of the needs of the families can be assessed, as well as all of the information can be shared across programs, whether that's internally within an organization or whether that's with external partners that may be involved in the family's life.
Great. And my last question, I am curious if there has been any conversation with JCCA around ways, real or imagined ideas to mitigate bio foster parent conflict in an effort to meet the child's social, emotional, medical needs.
Yeah, that's a really, really important question. We haven't gotten deep into the weeds of, using this kind of service delivery model to mediate that tension that arises sometimes between bio parents and foster parents. But I think, there's a recognition in our many conversations that we've had with JCCA in really thinking about how we bring bio parents into this model, and bring the foster family into the model during visits, you know, even in collaborative care conferencing, if that's possible, because I think when both bio parent and foster parent are sort of, you know, on the same page about a child's care needs, that might help relieve the tension. But the short answer to your question is we haven't gotten that deep into the weeds. I think it's definitely something important that we consider as we build out the model with JCCA.
Thank you, ladies, so very, very much for, again, such an awesome webinar presentation. We will be uploading the recording slides and resources to this presentation on ctatny.org within 2 to 3 business days. And here is a slide on the upcoming events that we will be having in the coming days and weeks. We definitely want to share this information with you, and feel free to register for these webinars. I'm sure you will get something out of them. Again, thank you so very much for being a part of this presentation to our participants, and have a wonderful day. Thank you. Bye-bye.
Thank you, everyone.
Thank you.
Thank you.